Thank you, Dr. Sanchez. Great to see all of you. Welcome, everyone, and thank you to our amazing panelists who are joining us today, and of course to everyone in the community who's here for this continued celebration of Pride Month, and also to learn from one another. So although I'm serving as chair now, at my heart, I am a teacher, and as such, I have to start with learning objectives. I'm going to review the learning objectives that were written out for today's panel, and then I'll introduce our panelists. So first, one objective of today's meeting is to continue to support the health needs of the LGBT community through advocacy and research. Next, we'll review lessons learned from evolving medical systems to support LGBTQ health, and learn from the experiences of serving as LGBTQ leaders and navigating careers in medicines as members of this community. So thank you for those objectives. And at this time, I'll present our panelists. So first, I'd like to introduce Dr. Lukejohn. He is a professor of medicine at UCSF and is the chief medical officer at Zuckerberg San Francisco General Hospital. His research interests center on organizational design, quality, and systems improvement, and efficiency models for healthcare system delivery to vulnerable populations. He's currently working on developing key innovations that can be implemented at the endoscopy center there at Zuckerberg, and he just so happens to be one of my best friends from medical school. So wonderful for you to be here today, Dr. Day. Next, I'd like to introduce Dr. Roy Gulick. Dr. Gulick is Rochelle Belfer Professor in Medicine and Chief of the Division of Infectious Disease at Weill Cornell Medicine, and he's an attending physician at the New York Presbyterian Hospital in New York City. Dr. Gulick's research interests include designing, conducting, and analyzing clinical trials to redefine antiretroviral therapy strategies for HIV treatment and prevention. He also serves as the co-chair of the U.S. Department of Health and Human Services panel on clinical practices for the treatment of HIV infection, and a board member of the International Antiviral Society here in the U.S. Dr. Gulick, thank you very much for joining us.
Thanks for having me.
Great to see you. And next we have Dr. Renee Salazar. Dr. Salazar is the Chief Equity Officer for the Broad Institute of MIT and Harvard. Prior to joining, Dr. Salazar was Assistant Dean for Diversity and Professor of Medical Education and Internal Medicine at University of Texas at Austin, Dell Medical School. In this role, he established the Dell Med Office of Diversity, Equity, and Inclusion, and led a team responsible for developing programs to increase recruitment and retention. Dr. Salazar, welcome. And last but not least, with the award for most beautiful background today is Dr. Julianne Sosa. Dr. Sosa is the Goldman MD Distinguished Professor of Surgery and Chair of the Department of Surgery at UC San Francisco, where she's also a professor in the Department of Medicine and in their health and faculty for the Philip R. Lee Institute for Health Policy Studies. Her clinical interests is in endocrine surgery with a focus on thyroid cancer. She's an NIH and FDA-funded investigator who's authored nearly 400 peer-reviewed publications and 80 book chapters. And she's the editor, my screen just moved for me, sorry. She's the editor-in-chief of the World Journal of Surgery and of Greenfield Surgery, Scientific Principles of Practice. So I am just so pleased to invite this truly incredible group to join us here at the University of New Mexico today. So if we could, I would like to go just panelist by panelist. I know I just said a whole bunch of your titles and accolades, but if you'd just like to say hello and just one or two words of welcome that you'd like to share with the group. Dr. Day?
Thank you very much. Hi, everyone. Happy Pride, even though we're getting near the end of the month. As Felisha said, my name is Luke Day. I identify as a gay male. I also identify as American Indian, Ogallala Lakota on my mother's side. And really happy to be here today and to share my experiences and my journey with all of you, and to share sort of what we are doing over in San Francisco, but to also learn from all of you as well. So thank you very much for having me.
Dr. Gulick.
Hi, everybody. Trip Gulick. I go by Trip. Speaking to you from New York City, where it's a beautiful 75 degrees and sunny, which is very exciting. The Pride Parade was yesterday here in New York, so lots of activity, lots of things going on in here in New York. I have lived in New York for many years. I'm openly gay man as well, and really happy to join you here in New Mexico today.
Great. Next, Dr. Salazar.
Right. Well, thank you so much for having me. So as everybody heard, I'm René Salazar, by pronouns are he, him, and I am in Cambridge, Massachusetts. Been at the Broad for 9 months now. So still settling into the new job, and have obviously lots of experience in medical education. Spent 20 plus years in medical education at UT Austin, Del Med, and at San Francisco, UCSF, where I know Luke from a long time ago. So really excited to be here. I'm also gay. I am a Mexican-American first-generation college student from the Rio Grande Valley of South Texas. And so we'll talk a little bit more about intersectionality, because I think it's such an important part of this conversation. Yeah, happy to be here and looking forward to a good conversation.
Great. Thank you so much. And finally, Dr. Sosa.
Yeah, Julianne Sosa. My pronouns are she, her, ella. With Lukejohn, we're both here in San Francisco. I probably can wave to him. I wanted to thank the organizers of this Zoom. And, my observations, I would thank Renee for bringing up the topic of intersectionality. And after last Friday, I'm not sure what part of my persona is most under fire. I'm obviously a woman, I'm gay, and I'm also Latina. And I think the complexity of intersectionality is something that we should touch on. I think of it as a superpower in some ways, but I think a lot has become even more in jeopardy over the last several days. And the other thing I think I would say is, as maybe the lone surgeon, it sounds like in this group, speaking from the perspective of the surgical community, which I think sadly has lagged behind many other specialties with regard to issues that pertain to diversity, equity, and inclusion. And I feel very compelled as a leader that all of us on this Zoom and our allies must be agents for change.
Thank you so much for that. Your comments just make me think of the huge breadth of work as we define it as diversity work, right? Like if we think about all the aspects of care, when we think of equity, when we think of justice, and what diversity encompasses, all of these major issues are things that I think we're making headway in terms of owning in broader ways. Like there's no longer this idea that just the diversity lead does the work. All of us are kind of stepping forward, I think, in new ways to own the important work and the challenges that lie ahead. And I can hear just from your intros that all of you are doing that. Well, today we really would love to focus on the idea of health disparities in the LGBTQ community. And so I have a few structured questions I hope that we can start off with, but I'm also happy to receive questions in the chat that we could ask our panelists. And I think that I won't call each of you in order. If you would just kind of unmute yourself, and we'll kind of pay attention to one another. So whoever's unmuted first speaks first. So first question. What can we do as leaders to improve LGBTQ disparities and promote inclusivity?
Well, I'll tackle that. Yeah. So, I mean, I think the first is, leading by example, and that is speaking up and speaking out around these issues. And I will just say, as when I was a learner and I was a junior and even senior attending, when I looked around me, there was no one like me. And I was fearful. And I'm still afraid, but I think we must overcome our fear as leaders to use the power that we have to empower those who are disempowered. And you could say, well, give me an example, Dr. Sosa. So, every fall is residency applicant season. And I would say, since I've been speaking up and speaking out and writing pieces and commentaries about being LGBTQ in surgery, I've started to receive emails. And last fall, I was both happy and very sad to receive a large number of emails from medical student applicants for surgical residency who said, Dr. Sosa, I'm going to be applying for surgical residency. I have been counseled consistently to not talk about sexual orientation or even to lie. What do you recommend? And I recommended to not be quiet or to lie, but rather to speak openly and frankly. And the reason I say that is because you need to know, right? You need to know if the community or the culture that you are thinking of joining is a hostile one, in which case you don't want to be there, or if it is a welcoming one. So I would start this conversation by just saying, as a leader, I think we must overcome our own fears and insecurities and lead by example. And the other thing I would say is everything we do, we should study what we do as a surgeon scientist. And I would say we actively need to contribute to the body of scholarship in this area to inform the changes that we make going forward. Thanks.
So I echo what Dr. Sosa says. I think it really resonated with me as well. As she was mentioning, I was counseled when I was applying for residency, and that wasn't too long ago, not to disclose my sexual orientation or even that I was involved in activities, so in community groups or in student-run organizations. And I think had I at the time had individuals at my institution speak up about there are other LGBTQ members in medicine, leaders in medicine, I think that would have made a difference. And so I think leading by example is incredibly important for us as a community. But I think just, sharing with who are we, what are our backgrounds, what do we bring to the table, I think is really important. We may not, a lot of people may not recognize it, but there are people in the room who it really will resonate with, especially if they feel like they're the only individual there. I think the other thing I sort of want to dovetail off of what Dr. Sosa said is that I think many of us, we may not recognize it, but we are in positions of power a lot of time. So, leading by example, if we see something or hear something in a room, it's really important for us to raise that issue, have those discussions, and really, I think, protect our learners, protect our patients, but I think really, trying to advocate for everyone. And so I think that leading by example and recognizing the positions we're in and helping it really try to change the narrative and move forward on this.
I'm going to jump in and support what I've heard so far. I would say let's be out. As leaders in leadership positions, we really do have that responsibility and that right and that privilege to really be out about who you are and let people know. And that demystifies it to a lot of people, makes it more familiar, makes people more comfortable. All of that is good. I agree with the message to speak up. If there are things that aren't right, that need to be corrected, we need to speak up as much as we can. I would add, let's support one another. And so you get to know a network, and talking about it like we're doing today is exactly the right way to do it. So share experiences, go out for a drink or go out for dinner, meet other people, get to know one another, and then support each other through this. And then lastly, just to echo some of the comments from the beginning, we are one group. There are many other groups who face similar or related challenges. And we need to be open to that, because if you can raise one boat, you can raise all the boats at the same time. And so being open to others, understanding what the similarities and differences are between groups who've been traditionally oppressed or are oppressed today, strengthens us all and makes us one big community, which is what we should be.
Hey, Dr. Salazar, did you want to jump in on that one?
Nope, I agree with what everybody said. I think, for me, the other thing to remember is, it's also important to get other folks in the room who can support us. I think if somebody, I suspect we can all connect with this, who's been the only person, raising a hand when questions come up around diversity, equity, and inclusion for 20 plus years. What I've learned is that it also takes our allies to help us move this forward. And so I think, for those people to acknowledge their power and their privilege, we all come at it from different angles. And so I think that's part of this conversation, because, this can be exhausting work. And I also want to just comment that it's okay for us to rest, right? It's okay for us to catch our breath and to step back, because, especially now more than ever, when it seems like the assaults just keep on coming, rest is such a powerful demonstration of resistance. And that's something that I'm really embracing, now that I've been in this space for so long. And it's okay to do that. I think we forget that, and we should make sure, especially our young learners, appreciate that, because it's so easy to get burnt out if you're not careful.
Great, thank you all for that. We do have a few learners on the call, and so I want to follow up with a question about kind of how so all of you are in leadership positions at these places where you've been welcome, and your skills and your identity have all been very valued. But I imagine that along the way, that wasn't always the case. And so I imagine there might be some learners here who are thinking, like, how do you do that? Like, how I did hear from Dr. Sosa of this idea of like making sure you're looking for the places that are inclusive and will welcome you. But as you start into this journey in medical school and residency and then into academic institutions, what were your strategies and how did you kind of take those steps in trying to understand whether or not the environment was welcoming and how you could be how you can share all parts of your identity in those particular environments?
Well, I thank you for those generous comments, but I would actually say I don't always feel welcome. And I'm not talking about UCSF. Obviously, I think all of us in life travel through very complicated roads, right, and streets and pathways. And I would say in American, and even more than American surgery, and international surgery, I don't always feel welcome. And I think that, and I'm not sure if it's because I'm a woman or because I'm gay or because I'm Latina or some combination of those things, or maybe I'm short, I don't know. But so you don't always feel welcome. And I think the question is, how we as leaders can create communities where there is belonging. And I have to give the University of New Mexico credit. We haven't done this at UCSF, but I'm stealing this idea that we are creating an environment like this where we're talking about these issues openly and freely and connecting people to mentors and sponsors. And I would say one of the things growing up that I never had, and I mentioned this, is I never had a role model. There was no one like me, and it was very lonely, and that made me very sad. And so I think it's creating mentors and sponsors, people you can turn to for advice and counsel. I secondly, talked about data, and I think a big problem in American surgery is we don't have any data. We don't really understand our community. We don't understand our patients along these axes. Really, the first study of its kind looking at LGBTQ learners in American surgery was published this year in 2022, which is, we should be ashamed. In that survey, it's very interesting, about 5% of survey respondents, they were assured anonymity, about 5% said that they were self-identified as LGBTQ. The astounding thing from that survey was that nearly 60% of the respondents said that they had been the target of discrimination. So what's my observation? I think we've made an immense amount of progress, but clearly there is still so much opportunity left. And I would say in surgery, it starts with data, learning more about this community and how to improve it.
Those are wise words. I think I would add my piece of advice for people who are trainees coming through the system is follow your passion and find where you want to be and what you want to do and follow it. And how do you figure out if that's the right thing to do? I'm an infectious disease guy. So I was drawn to this field very early on. I was a medical student here in New York during the beginning of AIDS, when almost everybody died within 2 years of a diagnosis. And that really raised passion with me. And I aimed my whole career at helping people with HIV, living with HIV. We didn't even say that back then, and we do today. But that was my passion, and I followed it and kept following it. How do you make sure that the place you are going to is right for you? Well, go and then talk to a lot of people. All medical students have people ahead of them and who've gone to these programs. You can find contacts. You can talk to people, do your web research, figure it all out. There are many places in the country that are now welcoming of our community, and more as time goes by. We are facing adversity, as noted, to the next level as of Friday, but we'll get through this, and we need to support each other and work forward. So follow your passion. That would be my advice.
So I completely agree with what's been said. Definitely follow your passion in your heart of where you want to go, because I think that will definitely make it a much richer experience for you. And I think also what was mentioned is really investigate. So one, learn about the institution itself. So visit the place. There are many things probably online you can learn about sort of what they promote, what they believe in, what they're committed to, but then leverage your network. So we're all here. Definitely feel free to ask us, or we can even refer you to people at some institutions just to really learn about what the culture is like there. Because many times, especially as learners, you're going to be there for many years, and it could be a couple of hard years, especially early on in training. And so you want to make sure that you want to be at that space, but that space also supports you and promotes you and is really in line with your thinking as well. So I think, again, it's really follow your heart, investigate, and really leverage your networks to understand the community you're going to be joining.
Yeah, I would agree with all that. I think the other thing to remember is, you can also create community outside of your sort of educational experience, right? So for me, I had the fortunate training at UCSF, where I was in internal medicine and spent 17 years there. But I also had a really strong community outside of my work community. And so it's important to acknowledge that, particularly if you're in certain spaces. And I'd also remember the power of networking across institutions, and I know that the medical student group has just launched actually within the last couple of years and has been revived. And so I think it's so powerful for those who have the option and opportunities available to them to attend these meetings, to network, to meet other students from other schools and other programs. I mean, that's really, really powerful. And, creating that network can be something that can help you get through some of those rough spots, but also can just be fantastic in terms of making connections that ultimately can help you in so many ways. And so just remember the power of that as well.
Great. Thank you all for that. Some really important points for our trainees in terms of following your passion, really talking to a lot of people and doing your homework, as they say, leveraging your community, and then not forgetting about that community outside of work. So that's great. Thank you all. So let's talk a little bit beyond kind of your personal experience and talk a little bit about your institutions, if that's okay. Let's talk about what your institutions do to improve inclusivity for learners, for faculty, for staff, and then maybe even for patients.
I'm happy to
go ahead.
Luke, you go ahead.
No, I insist. You go first.
So I'm at Weill Cornell. The medical campus is in New York City, on the island of Manhattan. And diversity, inclusion, equity is a part of everything we do now. And it's really increased visibility and efforts over the past, I'll say 4 years, maybe 5 years. We have a dean of diversity. She's in my division, a wonderful person. She's got associate deans of diversity and inclusion, which is great. There's an office of diversity, equity, inclusion here, regular seminars, including all groups, incredible number of groups that are considered and bringing people together. So really, I would say it's a part of everything we do. I do a lot of interviews, and we really stress, looking for a diverse group of people that look very much like our population. I think we always brag in New York City that we're the most diverse city in the country. I'm on with San Franciscan, so maybe we'll have a fight later, but it'll be a fun fight anyway. So we really look for every kind of person for our trainees, whether it's our students, our residents, our fellows, faculty hiring. These kinds of issues come into play basically on every level at this point. Very impressed with the level of discussion. You, Felisha, you added patients at the end, and our electronic medical record has been fixed in terms of claiming your gender and what you want to be called and what your pronouns are, and all of that is now in the medical record, which was, to some not familiar with the issue, seemed trivial. And we pushed it and talked about it and explained it, and it was embraced. So I'm pretty happy about that. I'll stop there. There's lots to talk about.
I would just say, for our department, I didn't generate our logo, which is transforming surgery through creativity, equity, and community. That was generated by our faculty. And I think organically represents where we're centered. And I think it's pretty unique among departments of surgery that those are the principles that rose to the top. And so I guess I would answer your question with, you got to create a culture and a community that is principled around, and really organically in their souls live this. I think secondly, we need to be not closed in our efforts, but open. And I think that's around training allies and encouraging allies and empowering allies in our larger community. And so I think it's educating, empowering, training, all of those things. I think some great comments have been made about the principles of recruitment, but retention is super important. I think too often people are on the offense when you actually, in a pandemic, have to play a lot of defense right now. And I think we're worried less about bringing people than not losing people. And so a big area of focus for our department has been salary equity. And I am sad to say we have huge opportunity to do better. University of New Mexico, public institution like the University of California, which is great because it's all public. You can see it all. And that really, I think, empowers leaders to take action.
So I'll just mention quickly, even though I'm currently at the Broad here in Cambridge, I still have my appointment back in Austin at Dell Medical School, which is part of UT Austin, and just left within the last year. So, prior to my departure, we were doing quite a bit actually to support the community. In fact, the med school opened in 2016, and one of the first student groups that we formed was the Core Medical Association. I wanted to make sure that students understood we had a space for them and that we were a welcoming space where students could really find that sense of community. And then we began to build out. And I think, for us, it was about how do we track folks? How do we support them once they're in the space? That recruitment piece is a big part of it. We had targeted social events during the interview process for medical students where they could meet folks from the QMA and get to know the community. We focused on race, ethnicity, and gender as well, but it was really important for students to start seeing a focus around the LGBTQIA community. And I think that was really something that schools are just now starting to do. We started doing some of that back in California, and I know that work has picked up, but I think it's really important though for students to see this early on. It's hard to track numbers, right? So I think part of the challenge here is how do we know who's applying and who's not applying? And we're now starting to capture that in the secondaries, but again, really pushing for change that we can better document and capture who the community is. I think it's such an important part of this. Creating that inclusive space, make sure that students understand, and learners, whether it be a student or a trainee, that they are supported, that they've got, they have the Office of Diversity, Equity, and Inclusion at the med school. We had a GME, Director of Diversity. And so all these roles that were there to support them throughout the process is important. And also make sure that their voices were heard. We had a lot of students who would raise issues in the curriculum and the way cases were written. And so we went to great efforts to make sure that when those issues came up, that we responded in a sensitive way and in a timely way. And I think, all these things are things that matter. And then finally, making sure that our students had a chance to connect with other faculty. Austin actually has a large LGBTQA community. We have a pretty robust faculty. And so giving our learners a chance to connect with faculty at all stages in their training was really important as well. It was really exciting to be part of UT Austin, where we also partnered with the campus and part of the work they did. And so that for me was the thrill going back to a place where we had the undergraduate piece, because there was so much energy and enthusiasm that we were able to partner with to create an even more welcoming space for folks that were up in med school.
And I'll finish up on perspective from my institution. So I'm also based at the University of California, San Francisco, but over at our county hospital. So the San Francisco General Hospital, or Zuckerberg San Francisco General Hospital. And we sort of have approached it over the last couple of years. And just like Tripp had said, we've had, I think, a lot of rapid change over the last couple of years, very much for the better. I think it really has started from an institutional commitment to diversity, equity, and inclusion. And that really started with our executive team, really stressing the importance of it. But I think really following through on, what are going to be our specific action items in terms of how we're going to improve it on our campus, both for our staff and for our patients. And so as part of our strategic initiatives, we have diversity embedded in it and embedded throughout all of the measures that we've developed. And then I think the next is really around how do you empower your staff at the local level to really drive this work and to really celebrate that work. So, we have a diversity council that includes trainees, patients, our faculty and staff. We have diversity champions in all of our departments. We have racial humility training that all of our staff go through. But really, we've created a space where we can have these discussions in each of our departments around how we promote diversity, equity, and inclusion, both for our staff, but also for our patients. And I think back to Dr. Sosa's point earlier around data, we have really made a tremendous commitment to capture a lot of this data on our patients. One, so we can identify where disparities may exist. And then also not just to sort of collect that data, but really then to begin to act upon it. And so really what we do now is for all of our operational areas and departments, we require them to stratify all of their data, especially their quality improvement data, by Weill and SOGI. And then if they identify disparities, then they have to develop an action plan in terms of how they're going to correct them. And so I think this has really engaged our staff around the importance of diversity, equity, and inclusion, but then really giving them the tools of how to act upon it and how to really drive change in this area.
Tons of incredible work happening at these different places, and really interesting to hear from all of you in terms of the different areas that you work in particular. Now, I was just going to take a pause for any questions from the group before I continue on with the structured questions. So I am actually going to read out Emma's question. Emma is the assistant director at our Learning Environment Office. So I'm going to read out her question if we can have the group respond. This is such an exciting and rich panel discussion so far, and I appreciate all the panelists. A question we always have to ask in DEI work is whose voices are missing? Who do you think is missing in today's space, and whose voices do you wish were present? Thank you, Emma, for the question.
One thing I'll say is we talk a lot in academic medicine about faculty and learners and patients. And I think our staff are a group of people that go underrepresented and uninvolved, and yet I think are the most diverse part of our community and the most vulnerable. So I would love to try to make sure that staff feel included in a lot of these conversations.
Yeah, I would agree with that. I think staff tend to be excluded and totally support that idea. And it's really exciting to see more and more places acknowledging that. I think in terms of others within the LGBTQIA+ community, our members from our trans community, particularly we think about intersectionality and just the disparity of the inequities that members of the trans community, especially Black trans women, are experiencing. We have to put that out there. We really have to have an understanding of that experience. It's just so unique and a powerful one. I think it's important that we're seeing more and more. There's more conversations around gender and gender identity. And so for me, I think it's making sure that we create spaces for those voices to be heard.
to add, I think in the healthcare setting, young men often don't have a voice. And if you look from the HIV point of view, the communities most at risk for HIV right now are young African American and Latino men, gay men that we're just not reaching with public health messages, and therefore we're not hearing them. Young men typically don't access healthcare routinely, and so those are voices that we are not hearing as much as we should, and we could do a lot for the community.
Great, thank you for that. A really important question. I'll go ahead and ask this next question in the chat. What efforts are made to increase Native presence in faculty, staff, and learners in your areas? And Michelle, I don't know if you're asking about Native presence in terms of LGBTQ populations. Do you want to jump in a little and add to that?
Sure. I was just asking in general, because we spend a lot of time, it seems to me, obviously we're spending time on in Pride Month talking about LGBTQ presence, but I feel like a highly marginalized part of our society is the Native communities, and having them in these discussions as well in all areas.
Thank you for the question. I'm happy to address that. Just also, I'm going to be the president of the Association of American Indian Physicians starting this August. And so as part of my 2-year presidency, this is one of the issues that I and our group are really going to be focusing on. One, really, how do we improve the pathway for students wanting to go into healthcare? So not just medicine, but nursing, nurse practitioner, physician assistants. So how do we improve and strengthen that pathway? And there are many people here on this call who are members of that group and trying to help with that. And then the other is how do we recruit, but also, as Dr. Sosa said, retain talented American Indian and Alaska Native physicians and healthcare workers across the US. I wish I could say I had all the answers. I think UCSF could do a much better job. Just to kind of give you a sense, we have, I think, 3,000 to 4,000 faculty here on our campus. I'm one of 2 American Indian, Alaska Native physicians, and for many years I was the only one, and that hasn't changed. And so I think that just speaks to a lot of work that has to be done. And so I think one really starts with community. So really creating a community for American Indian, Alaska Native physicians to come together to understand the process. And we're actually doing this at our 50th annual meeting this year, where we're going to have an academic workshop that we put together to really help prepare young faculty or students who are just finishing fellowship or residency, thinking about faculty positions. I'm really giving them the tools and the support to be successful. And then I think it's really working with each of our institutions about how do we do better at recruiting a diverse faculty pool. So how do we make sure the institution's a welcoming environment, that it is leveraging its resources to help support this faculty member, and that when they get there, they have not only mentorship, but that they feel that they're a part of that department or that institution and really feel that support. And so it's a long journey ahead. And I think it's definitely, and I really appreciate, you raising the question, because I think it's one of paramount importance and one that we remain deeply committed to.
Yeah, I think there's so much opportunity here, and self-reflection. We can do so much better at UCSF. The other member of the Native American community is in our department. I think Lukejohn is Tassie Bongiovanni, but I would use her as an example of how incremental change occurs and then accelerates. So for us, it was recruiting our first faculty member who is Native American. She has embraced her identity, is very forward thinking, and has pushed and pressured. And we welcomed our first Native American intern this year. We're super excited, who said, I came because I saw Dr. Bongiovanni. And then we became the first department at UCSF to do a land acknowledgement at the beginning of all of our gatherings that are 10 or more faculty, staff, or learners. And you could say, well, these are small things, but they accelerate. With each gain, it becomes easier and things move faster and the change becomes larger. So we can do so much better, but I think we're starting, which I guess encourages me. And thank you, Lukejohn, for your leadership. You inspire Tassie.
Thank you. That's an exciting new part of your department, Dr. Sosa. Thanks for sharing that. I'm going to ask Dr. Saleh to read her question if she doesn't mind.
That probably means that there's some typo in there that makes the question not make sense. So I wanted to ask about the structural, like measuring structural change and the impact of that on transformation. So I believe many of the people at the in this group right now are trying or actively making structural changes to the environment, collecting pronouns for people, land acknowledgements, these steps that we're making to make our environments actively more inclusive. And I'm curious if anyone on the panel has been measuring the impact of the changes that they're making to create more inclusive environments, and if you had any recommendations of how we can measure transformative change.
I can share with you, it's a great question, some of the tools we've taken here at ZSFG. One is survey. So it's really just to collect that data. So there are a number of diversity surveys out there that actually have been validated and can help measure, I think, the question that you raised. It's really important to, and we've thought about this quite a bit, is to make sure that you do them sort of over a period of time, because the change is not going to happen, within a couple of months or even within a year. We do ours about every 3 years to really assess, one, how welcome does our staff feel here on campus? How do they feel we talk about racism? How do we feel we talk about racism regarding our patients? Do we feel we promote diversity, equity, and inclusion? There are a number of structured measures that we look at. And then there's also that space for comments, which really, I think, provide a lot of rich information for us to assess how we're doing. Other things we do is we actually look at, the representation among our faculty and our staff in terms of, have we made a difference in terms of becoming more inclusive and more diverse? And then we really look along many of our health outcomes to see if we've been able to address some of the disparities that we've identified there as well. So we look at it both from a patient, a staff perspective to really see if we've been making, some of these changes. And again, they are incremental, but I think it's really having a structured way of measuring them over the course of time.
The other thing I would add is accountability and accountability of leaders. And at UCSF, our dean, Talmadge King, holds all of the chairs accountable around finances, around academic promotions, research productivity, financial solvency, and a diversity report every year. We are scored on it. Opportunities for improvement are identified, and discussion is formally held. And I think that raises the bar and the visibility when this is one metric on a par with other maybe historical metrics that leaders have to speak to. And so to me, that's like the teeth, right? Like, this is critically important and you need to do these things.
One other thing I think that's done routinely these days is to look at the composition of different groups. So the incoming medical students and how that changes over time in terms of race and ethnicity and other markers. Interestingly, I don't think we collect sexual orientation information. I don't know if any of my colleagues do. And then looking at the residency classes with the same thing in mind, fellowship and our faculty composition too. And as Luke said, really following that, not over from year to year, but over the stretch of 5 or 10 years, and see if all the things that are being done are really making a difference in terms of who's here, who's showing up every day.
Yeah, I would agree with everything that's been said. The capturing the sexual orientation for students was something we started doing as part of our orientation practice at Delmed. So we sort of had a whole 2-day session around DE&I topics and had the students self-identify anonymously, and it really gave us some interesting numbers that we didn't capture when you looked at the demographics that came with ANCAPs or whatever system that they were using to apply. So that was really helpful. And I've been at 2 institutions where we've done the climate survey, and that can be really helpful to get some baseline data to track progress, particularly as it pertains to the climate, the workplace and climate, or the workplace environment for all levels, from students all the way to senior faculty. I think the key with that, though, is making sure that you do something with those responses, right? The challenge with these surveys is that you do them and you do them and you do them, and folks feel like there's a little momentum or a little change that happens. And so with that in mind, you want to do them with enough interval to actually create those programs that can cause change. And I think that's where things get a little tricky, but those surveys can be really helpful. And certainly, I think the question's a good one because it really gets to the heart of the matter. How do you really assess what works, what matters? And that's tricky. I don't think anybody has figured out the one solution to that. I think it takes a lot of creative ideas to really capture this from all angles.
One thing I just wanted to also add as well, too, is part of the accountability piece. And I think Dr. Sosa had mentioned this earlier, too. I think some of the best ideas we've had about how we improve diversity, equity, inclusion on our campuses really come from our students, our learners, and our young faculty. Many times they're the ones who are raising the issue, pushing the issue, and really forcing us to be better and holding us accountable. And I think that's really important. I think at an academic institution, you get a lot of that in terms of young people who are coming onto campus with a lot of wonderful ideas, wanting us to be better. I think it makes it a great place to work, but also it holds us accountable to making sure that we change and that we move rapidly with some of that change and that we're held accountable along the way.
Yeah, that's a terrific point, and I'm glad you raised that. I think it's an important one to consider. However, I also want to remind folks that we need to be very clear that we don't expect them to do that. The challenge with this is that the students or the learners or whoever we're talking about feel like they have to be the ones to educate leadership on these issues. And oftentimes that's the way this works. But we've got to be really clear about, we want to try to be more proactive as opposed to being reactive. Sadly, nobody's figured out a way to do that very well. I think that's about to change and is changing. But I would agree with that. And then back to the accountability, and also I think really adding weight to this work, stuff that I saw you just before I left was really adding this to the promotion process, making this part of sort of promotions. And, I know that's how I was able to promote all the way to professor was because of the fact that I did so much diversity work. And so really making sure that we give this work the weight that it deserves. I think that's the challenge. We're all doing this sort of part-time or in the evening, and so we have to find a way to really incentivize it in a way that matters. And that takes a lot of change and a lot of education on parts of many people, but that's such an important part of this conversation. So much of this work has been done for free, and we really have to start acknowledging the fact that this takes time and effort, and we need to compensate and acknowledge that accordingly.
Great, thank you all. Yeah, the 2 important reminders there, right? Like if our students are wanting to take on some of that work, they should be supporting and we should support them, but they should not be carrying the burden on their shoulders. That needs to be on us. And then those faculty and residents and students who are doing the work, they should get credit for it. And so thinking of ways to make sure that happens. So thanks for those important reminders. So I have a couple of last questions, and I'm sure like everyone in California, your stomachs are grumbling because it's almost lunchtime. So we'll just do these 2 couple questions and wrap up. What do you all see as the biggest challenges facing the LGBTQIA+ community in healthcare today?
I'll start. I think for me, one of the things, and this has gotten better, but we still have some ways to go in terms of how we educate our learners. I've seen that this has become part of the curriculum in med schools, but it's so inconsistent in how we train the next generation. And so I think really making sure that this is part of the curriculum, that we have dedicated space and time so that students are well equipped to take care of the population. I think right now, again, it depends on where you trained, where you went to school, where you did residency. And so we need to be a little more consistent with that. For me, I think it also means having more leadership that sort of represents the community. Having, sort of students, when they can see us, they can be us, right? So we got to make sure that we have people in those spaces that can do this work and but to carry it forward. But for me, it's really about education and capture more data. You know, I'll go back to the intersectionality point. You know, we have some general ideas of inequities in health when it comes to the community, but we need to dive a little bit deeper and I think really start to get a better sense of the layers of intersectionality, right? Because the more you add on, the more complicated it becomes. And so really trying to ask those questions and make sure that when we capture data around one's sexual orientation or gender identity, that we really try to connect it to race, ethnicity, socioeconomic status, abilities. You know, we're seeing so much in terms of the ability, accessibility role. And so we've got to start connecting those dots because, you know, every person is a representation of so many layers of difference. And so for me, that's such an important part of this work that I think we're missing. I think, you know, we get focused on one particular element. And so we've got to bring that intersectionality lens back and make sure that we think about this moving forward.
Yeah, I would just echo what Renee said. I think definitely education, you know, not only for our students, but also I think for other healthcare team members, really just being attuned to this topic. I think the other thing too, and really just want to echo what Renee said too, and I believe Julianne said this at the beginning, is just having better data out there. You know, I'm a gastroenterologist by training, and this is the first year that we actually had an entire literature review on LGBTQ health within the sphere of GI. And sadly, there just wasn't a lot of data there. And so I think it's really important that we collect this data, we look at this data, because without having that data, we can't really know what we're trying to improve upon, what we're trying to address. And really, I think we need that to be able to sort of, you know, move the needle forward in terms of funding, research, investigators, and really, I think, trying to improve, I think, our overall health outcomes. And so I think really much more of a push on collecting this data across many dimensions.
Yeah, those are really good points. And I would just add that LGBT health has not been a major focus of the NIH so much over the years. There's not been a push for it. And I think the more we talk about it and say, hey, we need to study this, we need data, there's a real opportunity, I think, for people, for trainees, if you're thinking what you want to do with your career. LGBT health is going to be an area that gets a lot of attention and needs it, and could be a super way to focus your career if you're passionate and interested.
Yeah, I'm just worried about the political landscape around us, and I guess I don't have any insight. I don't know what is coming, but I think we need to probably have more of these conversations and be even more active and intentional to what we do. I'm just worried everything could become more precarious, and yeah, that's what worries me, I guess.
Yeah, thank you for that, Dr. Sosa. A lot of what is on my mind is about how we probably in upcoming months, years, are going to need to be able to straddle the role as clinicians, leaders in academic institutions, but also community advocates when it comes to some of these major issues that are upon us. And so I think all of us are probably internally grappling with what that means, and also maybe putting our foot into some of the water of like bringing some action to that.
Yeah. Well, and I want to just acknowledge that point, because I want to remind us that, you know, this is hard work, and we've also got to take care of each other and ourselves, because, you know, this work is incredibly difficult. You know, the last couple of years of the pandemic, after George Floyd was murdered, now with everything unraveling, you know, I just want to make sure that people understand the need for self-care, understand that it's okay to take a break, it's okay to rest. You know, rest is powerful, and it's okay to talk about mental health. You know, it's okay to talk about the vicarious trauma that we experience when working with students or trainees or staff. I mean, all of that is an incredible way to carry, and that's something we don't talk enough about as leaders. And so I want to make that clear, that we've got to have that space to have these conversations. It's okay to hit the pause button and step away. Because if you don't take care of yourself, nobody else is going to do this work. And so if there's anything that folks remember from what I say, I hope that's the message that people walk away with.
Thank you so much for that. That's super important. And just to highlight what Dr. Vankovic was pointing out in the chat, there's some structural issues around partners being able to get health insurance, things that are kind of what we might consider even basic that still aren't in place, issues around gender affirming care that will continue to be a part of the healthcare landscape. I see Dr. Sanchez's hand up. Dr. Sanchez.
Yeah, I just want to say thank you everyone for your comments and just following up to Dr. Gulick's thoughts about NIH. It's really important for us to stay active for federal agencies. It was exciting a couple of years ago when NIH launched the Office for Sexual and Gender Minority Health, in part because up to that point, SGM communities were not considered a population with health disparities, or at least a population that NIH recognized as a community with health disparities. But that has changed. So now in many of the NIH grant proposals, LGBT and also SGM is covered as a health disparities population. So that was a huge win with the establishment of the office. And just during this month, we had Dr. Cano from our Cancer Center and Dr. Sanchez, my brother, who just received an NIH grant on building the next generation of LGBT cancer researchers. So now there are pipeline programs and pathway programs. So please, apply for those awards, apply for those programs, really critical to move NIH forward. So thank you, Dr. Gulick, for bringing that up.
So we have just a couple minutes left, but a really fun question that I hope each of you can answer in just a moment. If you could go back in time and talk to yourself, either in college, med school, residency, whatever time period you feel like you needed to hear the message, what would you say? And would it be by text or by FaceTime message or even in person?
All right, I'll jump in and say, wow, I wouldn't want to do it by text, but maybe FaceTime is probably the best way. I think meeting your former self face to face, you might both disappear. It's quite possible. I would say to my younger self, be confident, be proud. Realize that your family and friends love you and they want to support you and are here for you. So lean on them and go be yourself and do what you want to do. And you're gonna, if you can do that, follow your brain and your heart, you're gonna live a life that you can be proud of.
Wonderful, thank you.
I'll go. I'm a texter, so I probably text myself. To be patient and remember this is a marathon, not a sprint. I think if I reflect back on this journey, sometimes getting so frustrated with the lack of progress or feeling like, wow, I'm not making a difference. But, it truly is that marathon and that's okay. So to be kind to yourself, give yourself grace to mess up. And most importantly, love yourself because this work is important.
I think I would probably do FaceTime as well, just because I think a younger me would want to see what I would look like in the future. And I think I'm pretty direct, so I think I would say it's going to be okay. Especially early on in my life, I never thought I'd be where I'm currently at. Just wasn't something that was expected or that was something that was achievable in my family. And just to tell myself that I think what others have said is like, it's going to be challenging, but in the end, it's going to be all right. And you are going to have just a really wonderful life ahead of you. And so enjoy it.
I don't know. Don't sweat the details. I got in the weeds so much and I sort of miss big picture things. So don't sweat the details. And I'd probably tweet it out so that everyone in the world could remind me of that, because I'd probably the next minute say, that's not right. I'm going to go back to what I was doing and sweat the details. So that's what I do.
All right. I don't know. Get creative. I'd make a TikTok. Okay. I admit it. All right. I'm a TikTok kind of guy.
That's amazing. Well, it has been such a pleasure. I am hoping that Dr. Day, when he's talking to himself in the past, will let his young self know that I'm still around this many years later. It was such a pleasure to have these amazing guests this afternoon share with us so much about yourselves and the important work that you're doing, your leadership and your passion. Really appreciate all of you. Thank you so much. And we hope to stay in touch. And thank you, Dr. Sanchez, as well for the platform. Hope you all have a great day.